Welcome to the AUA University podcast, where we deliver evidence-based discussions that inform and advance urologic practice. I'm your host, Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today's topic is Genitourinary Syndrome of Menopause, GSM, a condition that significantly affects postmenopausal women but remains underdiagnosed and undertreated. We'll review highlights from the 2025 AUA Guidelines on GSM, which represent a multidisciplinary collaboration among the AUA, AUGS, SUFU, and other societies, with funding from the Patient-Centered Outcomes Research Institute and endorsement from leading sexual medicine and menopause organizations. Our discussion will focus on key guideline recommendations, practical treatment strategies, patient counseling, and ongoing advocacy regarding the FDA's black box warning. It's my privilege to welcome two distinguished experts. Dr. Tracey Wilson, Professor of Urology and OBGYN at the University of Alabama at Birmingham. She's a member of the AUA, AUGS, and SUFU Guidelines Panel, co-director of the URPS Fellowship at UAB, and a member of the SUFU Executive Committee. We also have Dr. Una Lee, head of the Section of Urology and Renal Transplantation at Virginia Mason Franciscan Health, Associate Clinical Professor at the University of Washington, and Associate Program Director of the FPMRS Fellowship at Virginia Mason. She was also Vice Chair of the 2025 AUA Guidelines on GSM. Dr. Wilson, Dr. Lee, welcome, and thank you for joining us.
Thank you, Dr. Gonzalgo, for having us. It's great to be here and to be able to discuss with this important topic with our colleagues. It was such a great honor to be included on the guideline panel. It was a very unique experience where we were collaborating across the table, lots of specialties that don't necessarily see ourselves in the same room, but this was something that was very near and dear to our hearts. And so we were joined by urologists across the country, urogynecologists, as well as internists. And this guideline has been supported and endorsed by, as you mentioned, not only SUFU and AUGS, but the Society for the Study of Women's Sexual Health, as well as the Menopause Society.
And it's made a big splash on social media, the public, clinicians, patients alike it's been very well received, and people are really excited about it. So it's great to get it out here. We did just look at the 2024 AUA census data, and out of 14,000 urologists that were surveyed, 50%, almost 7,000 urologists do treat GSM. And so that's amazing. Primarily it's female, gender, private practice, and general urologists who are treating GSM. And there is opportunity for male subspecialty and academic urologists to become more comfortable and treat GSM. And they use it for local symptoms, dyspareunia, and also recurrent UTIs. That penetrated through, but we have more opportunity in other areas. Thanks.
Great. Thank you for that background. And, to begin, let's define GSM and discuss how it presents in clinical practice. For instance, when a patient says something like, I just feel irritated down there, what are we really talking about?
Sure. Well, GSM, as mentioned, it's a syndrome. So it's a constellation of symptoms as well as signs. But there isn't a clear definition that the person has to meet, have to have 2 out of 5 symptoms in order to meet the criteria for the diagnosis of GSM. And as Dr. Lee mentioned, the symptoms can sometimes be urinary, they can be vulvovaginal, and which oftentimes lead to sexual symptoms. So these all are occurring because of physical changes resulting from declining estrogen and androgen concentrations in the genitourinary tract as the woman progresses through the menopausal phase. So it is a decline in both androgen and estrogens. And oftentimes the urinary symptoms that we might see include urinary frequency or overactive bladder. They may have recurrent urinary tract infections. They also have vaginal dryness. They may have discomfort with intercourse. And then this may then lead to issues with libido and female sexual arousal disorders. And on physical examination, the things that we often see are the vaginal dryness, but it's so much more than that. Patients may have atrophy of the labia. They may have a narrowed vaginal introitus. Again, you'll see the loss of rugations and a lack of moistened tissues, as well as you may see petechiae, or the patient may also experience bleeding after intercourse. So all of these things can be present, or only one can be present, but that doesn't mean that she does not have GSM simply because she only has one sign or symptom.
Absolutely. I would say it's a clinical diagnosis. Patients come in, it's very common. They may or may not know about it. They may not want to talk about it. But I think we need to have a high level of engagement with patients and our colleagues about this. There can be signs, there can be symptoms. And you can also have coexisting diagnosis. That's also very common. It's common to have overactive bladder and GSM, or like recurrent UTIs and GSM, right? And you can treat and evaluate these individually, knowing that there is some overlap.
Great. So, obviously, I think it's important to recognize GSM as a chronic treatable condition. And because of it, it's very critical. We understand that for our patients. And I would think that urologists are often the first providers to identify these symptoms, making our role really essential in multidisciplinary care.
Just as Dr. Lee pointed out, that we often see this diagnosis because they're sent to us for recurrent UTIs. But we definitely need to be aware of all the other signs and symptoms that can go along with that.
I think urologists have been leaders in this field, actually, to take this on. And this guideline started years and years ago, where we proposed it to the AUA and said, this is something that's really important, and we should embrace it. We should know more about it. We should look at the evidence, and the evidence is very compelling and very strong. We certainly want our gynecologic and our primary care colleagues to learn more about this, get educated on this, because they can certainly do this as well. But we're definitely in this.
Great. So let's discuss the therapeutic approach. When someone finally gets a diagnosis, what are the most effective evidence-based treatments for GSM?
Absolutely. One of the guideline statements is that one of the mainstays of treatment is local low-dose vaginal estrogen. This is a local treatment. It can be a cream, it can be a ring, it can be a suppository, but it is safe and effective for the treatment of these symptoms. And it does come with some caveat, meaning patients need instructions, right? They need to understand why they're getting prescribed it, how to use it, and that it's safe. I would say those are some of the barriers that people maybe don't follow through or don't understand it. But the safety is a big one, and we'll talk about that.
And I think that the mainstay of treatment is the low dose vaginal estrogen. There are other options, and we can get into that as well. But it's definitely requires shared decision making. And most importantly, making sure that the patients know that treatment is available. This is not something that they should just live with. In fact, studies show that only 50% of women are receiving this. So based on the AUA census information that only 50% of urologists are treating, well, only 50% of patients are actually seeking treatment. So there's a whole segment of patients that are not being addressed. And again, the word needs to get out that these are real symptoms with real treatments.
Great. So local estrogen remains obviously a cornerstone of therapy that's supported by robust clinical evidence. However, patient education and reassurance are essential to ensuring adherence to anything that's recommended.
Yeah, I would say, once you diagnose the patient, you suspect it, right? You have a high index of suspicion that GSM is their diagnosis, and you explain it. I think you've got to get into the nitty-gritty with the patient a little bit and really explain how to use it. It's a local, sometimes some of the things I say, it's a local cream. It's applied to the urethra, vagina, bladder area through the vagina, and it's twice a week, a small amount, 1 gram, let's say. And I really give them more explicit instructions about you can put it inside, you can put it on the outside, and that it will take some time to get the full benefit. So it's not an instant cure, but you've got to be consistent with it for 2 to 3 months to get the full improvement. Dr. Wilson, what are some of the things you tell your patients about how to use it?
Well, I think that you definitely, we've talked about it being low dose, and I don't really think the actual definition of low dose has been clearly defined. And you mentioned 1 gram. Sometimes you can say 0.5 grams. It is packaged. I tell my patients it's packaged like yeast infection medication. Unfortunately, many women have experienced a yeast infection medication or vaginal candidiasis over their lifetime. And so it comes with an applicator. And because the vaginal tissues are fragile, that applicator can be somewhat uncomfortable. So if the patient is comfortable with her own self-exams, and I ask her to place the cream on her finger and then place it into the vagina and around the introitus. And oftentimes I say the size of an M&M or the size of a dime, not bigger than that. Everyone can understand what that is. Because when they use too much, then oftentimes they will have some vaginal irritation. If they use the applicator now has to be washed, and you have a lot of medication that is going down the drain. And depending upon insurance coverage, it can be costly. But it is something that's more readily available to most of our patients as opposed to some of the other therapies. So
I would say it could be individualized, right? The dosage can certainly be individualized to their needs, the exact amount. Right. And some people need a little more, some people need less. But that could be a conversation you have with your patients for sure.
And some women will be on oral estrogen replacement therapy, and they'll say, "Oh, I don't need it because I'm already taking, I'm taking something for menopausal, the systemic menopausal symptoms like hot flashes and the vasomotor symptoms that we talk about." And they really have to be educated that this is definitely local. And although they may be taking something for the systemic symptoms, that's not treating the genitourinary syndrome of menopause. So they should be encouraged to take the two. It is, very minimal amount of it is absorbed. Very few side effects. Of course, we have the warnings and we will get through to that. But again, should be encouraged, and it should be emphasized that it's safe.
Yeah. Right. So you can be on systemic, you can be on local as appropriate, right? If you need the local, you do the local. If you need the systemic, you do the systemic. You can be one or the other or both. And it depends on the symptoms that they're presenting with. Another thing you mentioned, Dr. Wilson, is that it can be expensive. Honestly, the coverage and the cost has come down very significantly over the years. So I would say with some sort of tips and tricks, it's definitely accessible on the prescription side, and coverage has improved, but even people can be creative about how they can get it, and it is more affordable these days. So finances should not be a barrier. But again, I like to discuss that with patients as well, so that I can understand, well, how much is it costing you, and what's your preferences, right, for that.
Well, I think that the estrogen is definitely more readily available to most patients as compared to like DHEA, which is another hormonal option, but is certainly a little bit more difficult to secure. And again, the formulation or the way that it is administered is definitely based upon the patient's preference. Some patients feel that the cream is too messy. Others feel that, they prefer a ring. And then, of course, we have ospemifene, which is the oral agent.
Yeah. And then there's a suppository as well, which is like a tablet that goes inside and absorbs and it dissolves. And usually each insurance plan covers at least one of these formulations. And so it could be based on insurance coverage. It could be on patient preference. They could have tried one formulation or another. But there are options, which is great. And the studies have shown that each formulation is equally effective. So you can be assured that whatever you're getting, as long as you're using it, is going to treat the symptoms and improve their quality of life.
Great. Well, thank you both for that, those comments on that particular area. Another area that's important has to do with counseling and safety. And you mentioned previously, and for sake of clarification, the use of local low-dose estrogen, right, actually has minimal or essentially no systemic absorption, and is not associated with any type of increased risk of, some of the cancers that or other medical conditions that we've talked about. When it comes to patient apprehension, which often centers on hormone safety, how should clinicians address these concerns?
Yeah, that's a great question. And it's really the elephant in the room when it comes to this. Patients and other clinicians alike have this sort of misconception, misinformation that hormones cause cancer. And as far as vaginal estrogen therapy, there have been very strong, large, even long-term studies that have really clarified the safety of vaginal estrogen use. And there was several guidelines on this in people with concerns regarding cancer or breast cancer, people even with a history of cancer, that you can reassure patients that it's safe based on all available evidence. And I think as urologists or as providers, we have to feel comfortable and really understand that, so that then we can translate that to the patients. They just have this fear that's based in some information that hormones cause cancer, and then they might hear it from another source, and then so you have to sort of break down that concern. And at the same time, it's shared decision making. You've got to really understand what are you worried about? What's the what do you like to understand what their thinking is, so that you can help them get some good information and make some good decisions about their health. What are your thoughts on this, Dr. Wilson?
Yes, of course. I think, again, it's definitely needs to be individualized. She may have concerns because of a personal history, or she may have concerns because of a family history, or just because of the concerns. Of course, we are taking women off estrogen who had been on estrogen for many, many years for systemic symptoms, and this is not that. But it's the same word. It's estrogen. So, in this field, it's a 4-letter word when it's been treated like a 4-letter word when it really isn't. And, so again, you have to do some education, in regards to helping her to feel comfortable. It's not unusual for me to give a patient a prescription for low dose vaginal estrogen, and it may be for UTIs or any other symptoms associated with GSM. And then when she comes back for a follow-up, she says she didn't take it. And why? Because she got home and then she read about it. She looked at the package insert and just was like, despite the conversations that we've had. So we do have a long way to go, but at the same time, you want to let her go at her own pace. And there are some patients who just can't, don't want to, or are having a hard time accepting that. And so sometimes we talk about non-hormonal therapy, such as different vaginal lubricants or coconut oils or some of the natural products. But she has to come around at her own pace. And sometimes it's like one more UTI. Okay, I'm ready. That was the straw. I'm ready to give it a try. But we don't want to force something on our patients that they're not comfortable with. But again, I think that the more that we educate the public and the more that we educate our medical professional colleagues, the more that we're going to see more patients being treated and feeling better.
Yeah, I would say that the data is compelling on the safety of vaginal estrogen in the development of cancer, personal history of cancer, family history of cancer, and even other cardiovascular risk, other venous thromboembolism. All these things have been essentially debunked, and so I think we can share that with patients with confidence. Some people really like to involve their oncologist in multidisciplinary co-management, and I have not had an oncologist who has declined that in a symptomatic patient who would benefit from this. So I do think it's an important conversation to have, and we should be, data-driven, use shared decision-making, and I think it's just going to get more and more sort of acceptable and comfortable. And I think that's great. I think it's great for women, and the conversations are happening, which is the wonderful thing.
And I think that, the thing that to definitely highlight in what you just said was collaboration with the treating oncologist. They've been great many times when you reach out, and every patient has a different, phenotype in terms of their cancer. And so she's probably not going to move forward unless her oncologist gives the green light. And many times they will do that.
Yeah. And another important story is just the power of advocacy. So there is a black box warning on all estrogen containing products in the US. And, it really doesn't apply to vaginal estrogen, but because it is an estrogen containing product, it's on there. And there's movements and a lot of, testimony. And the FDA chief has actually announced that they're looking to remove it. And we look forward to that. And that's a lot of effort of people and speaking up and talking about it. So the data would support it. The evidence would support it. And so I look forward to that that next step, which will also help women get over that sort of misinformation and fear.
Right. Safety reassurance, accurate information, and as you both have mentioned, shared decision-making are really key to patient confidence and successful outcomes. So it's important for patients to understand that, as we've discussed, local estrogen is not systemic hormone therapy, and education dispels fear. I wanted to follow up on what you just mentioned about the FDA black box warning and advocacy, because obviously that was something that was on all estrogen products and has long created confusion. Are there any updates that clinicians should be aware of with regard to this black box warning?
I mean, the update is that, as very recently, the FDA chief has received testimony. There's been a lot of efforts and coordinated by several organizations and individuals that it should be removed from these vaginal estrogen products. Just the timeline is not clear, but I think that will help patients. And again, remove one more barrier to getting to using it and feeling comfortable with it.
Great. And, this is another example, perhaps, of how collaborative advocacy can update policy and reduce barriers to appropriate care. So, in addition to this, we certainly need to continue to be our patients' advocates and help them understand that this label is perhaps out of sync with some of the science. Before we close, I wanted to actually ask each of you, some about success stories and perhaps some take-home message. So I don't know if there was something that you each could share with a success story or clinical pearl that captures the impact of GSM treatment.
Sure. I think that, some of the success stories that I've had are patients who, as Dr. Lee pointed out, GSM can be a standalone syndrome, or it can be associated with overactive bladder, recurrent UTIs, or what have you. And so many of the patients that I see may have recurrent UTIs. And, we're all trying to be antibiotic stewards and minimize exposure to antibiotics. And so it's not unusual for patients to have dysuria, which is a sign associated with genitourinary syndrome and menopause. But that's also a hallmark sign for a UTI. So it's not unusual for patients to receive empiric antibiotics simply on that symptom alone. And I send to my patients, it's like drinking lemonade with chapped lips. If you urinate and your vaginal tissues are very dry and uncomfortable, it's going to burn. You're going to have dysuria. And so they're like, why am I having dysuria and it's not a UTI? I need antibiotics. No, you don't need antibiotics. Your culture is negative, but we can get the environment more healthy with some vaginal cream. Meanwhile, they're overdoing it with hygiene products. They are avoiding sexual intimacy because they're thinking that the UTIs are associated with that. And once you can get them on the low-dose vaginal estrogen, and as Dr. Lee pointed out, some consistent use for 6 to 8 weeks, then all of a sudden they have an improvement in their quality of life. There's no longer being exposed to antibiotics unnecessarily, and are able to enjoy their relationships. And I think that that's been what's been most rewarding for me.
Yeah, I would say so many success stories. You think about prevention of UTIs, that's massive, right? For the healthcare system, for the individual patients. Treatment of local symptoms, urinary, vaginal, vulvar, sexual, and urgency and overactive bladder. I mean, that's huge. Patients are often willing to take that step to start and use vaginal estrogen, but they might be reluctant for an oral medicine. And it's a nice option that we have more options for patients that are safe and effective. And so I would just say it's one of the most rewarding areas that I've helped patients with. And I know that a lot of clinicians feel the same way. And so it is remarkable how far we've come and how much more we should come with this field. And I think, we have to always think about the patient and their perspective, and really preemptively counsel them, encourage them, educate them, and so that they can, move forward with this. One question we get often is, do I have to use this for the rest of my life? And, I always say, let's talk about right now. Let's be consistent. Let's use it. It's not a short-term treatment. It's going to be a little bit more long-term, but you use face moisturizer for the rest of your life. You brush your teeth for the rest of your life. You use your seatbelt for the rest of your life. You do a lot of things to maintain your health. And this would be another one that, you would likely, I think you would benefit, honestly. And so I don't want to always say like for the rest of your life, but I do think I like to say it's a long-term medicine with lots of benefits for you and obviously in the patients that we're selecting. So.
And just before we finish, I did want to, along those terms of long-term use, is point out the patients population that is not menopausal, is not perimenopausal, who could benefit from this treatment. And these are younger patients who have oncologic diagnoses that require anti-estrogen therapy. And they will definitely have symptoms of GSM, but they're not in menopause. They're not perimenopausal. This is the 28-year-old, the 30-year-old who has breast cancer. And she will experience, as a side effect of her treatment, symptoms and signs associated with GSM, and she should not be denied therapy.
Great. I think these moments really remind us why this matters and can help to restore confidence and quality of life for our patients. Before we wrap up, we wanted to acknowledge some breaking and historic news. On November 10th, 2025, the FDA and Department of Health and Human Services officially removed the black box warning from vaginal estrogen products, a major step forward for women's health. The AUA and the GSM Guidelines panel played a key role in advocating for this change, which recognizes the strong safety data supporting local estrogen therapy. I'd love to get your quick reactions. What does this mean for our patients, for how we counsel them, and for the broader landscape of GSM care?
Great.
Oh my,
This is great
yes.
news.
Oh my gosh, this is amazing news, and something that all of us in this space in treating patients with GSM were very excited about. And this is a major win for urologists, urogynecologists, family practitioners, you name it. And most importantly, our patients. So,
Agreed.
yeah, definitely it's changed my conversation with patients. In the past, you prescribe these medications. I, as a clinician, treating physician, know the benefits of this medication, but the labeling is definitely a barrier for some patients. And despite the patient-physician relationship and the trust that they have in me, when they go home and they're reading these package inserts and they're looking at their own family history or their risk factors, many times that, that's that lasting impression. And it's not unusual for patients to come back and have been non-compliant with my instructions and just didn't progress in their symptom improvement because of the fear. And now with removing of this labeling, I've been able to certainly talk to my patients with a lot more confidence. Of course, the things that are on the shelves right now in their pharmacy still contain that labeling. But I can clearly say that the FDA, as well as the Department of Health and Human Services, has heard us. We have spoken loud and clearly, and this is safe medication, and it is going to allow us to treat so many more patients. This has been unnecessarily denied for so many years. So
You
it
can't
certainly
see
has
me.
made a
Yeah,
difference in my practice.
definitely. You can't see me, but I'm like nodding my head and smiling really big to
Yeah.
everything you just said. So this is historic. This is a big game changer for the landscape of menopause and for women's health. Because number one, it's a story of advocacy, right? It's a story of collaboration. It's a story of scientific data making change. This has been our clinical experience that the black box warning, the fear of side effects, financial burden has been a barrier. And in my research in the study that was quoted during the press conference, this was pretty fun. We showed that, right? A proportion of women just, again, they were concerned. And the news that the black box warning going away raises awareness that this is, again, not based in any, grounded in any real data. It was just a remnant of some of a misinterpretation of data from the past. The black box warning is going to be removed from, most and certain estrogen containing products, but definitely the vaginal estrogen products. Some combined estrogen and progesterone products. The systemic estrogen alone products will have a warning about endometrial protection. So this is exciting, and it's great for patients. It's great for all clinicians. It's great news for urologists and the AUA. And it's a natural extension of our guidelines, right? That the GSM guidelines showed the compelling data about the safety, and a lot of people signed petitions and spoke up and testified, and the FDA took action, which is really great.
Absolutely. I mean, you hit the nail on the head in terms of the advocacy surrounding this, and can't thank the AUA enough, as well as all the panel members, and of course, Una and Dr. Kaufman leading us through this charge. But this was a group effort, and all with keeping our patients at the forefront. And so again, it's exciting. It's exciting to see that we do have a voice, that we can make a change when we work together as a team. And again, all of our patients are going to be the ones to benefit from this the most, because again, the fear was introduced unnecessarily, and this rhetoric just kind of continued over decades. And now we finally made some headway. So I'm so glad to see that, at the end of all this and all the hard work, we are definitely ending on a high note, for sure.
Absolutely. I think it gives patients more reassurance, right? They can be reassured by the scientific data, by our counseling, but just this, this removal of this black box warning will be just another level of, the FDA agrees that this is safe, and we know it's safe, right? Like it's a safe treatment, and it's an effective treatment, but this other level will absolutely help get it into hands of women, and they will use it. I think it's really going to make a difference.
Absolutely. And it doesn't end here. We're going to continue to charge on and be advocates for our patients in the same way.
This is a landmark moment that will reshape how we talk about GSM moving forward. We'll continue to keep our listeners updated as new guidance emerges. What an exciting time for evidence-based advocacy and women's health. Dr. Lee, Dr. Wilson, thank you both for a candid and inspiring discussion. For listeners, remember, genitourinary syndrome of menopause isn't a niche topic. It's a daily reality for many patients, and we can change that. By increasing awareness and following the 2025 AUA guidelines, urologists can lead in improving care and quality of life for our patients. For further information, visit AUA University at auanet.org/university to access the guidelines and related educational resources. I'm Dr. Mark Gonzalgo. Thanks for joining us. And as always, stay curious, stay compassionate, and keep learning.